In this particular section, we are going to discuss on the coagulation disorders. First of all, how to classify these coagulation disorders. Very basic elementary level classification is I'm going to do it a congenital coagulation disorder and an acquired coagulation disorder. So what are the things that come under congenital coagulation disorders? You are going to have two disorders again. 80% of the congenital coagulation disorders will be due to one particular disorder called hemophilia A, which is typically due to factor VIII deficiency. And remaining 20% is due to something called hemophilia B, which is again due to something called factor IX deficiency, which is also referred to as Christmas factor. There are a lot of other congenital coagulation disorders are there, but these incidences are very, very less and they're not going to make a significant percentage. So what are the other coagulation disorders? Like you have something called factor XI deficiency, which is also referred to as hemophilia C, and you have factor XII deficiency, and you have factor XIII deficiency as well. So these form a very, very minor chunk whose true incidences are completely unknown, and we are not really aware of how much is going to affect the population. Okay, we'll move on to the acquired. As you can all predict, acquired is going to be the most common among all the coagulation disorders. Congenital is very, very rare. Among the congenital, if they ask you, definitely it is hemophilia A. It's the most common congenital coagulation factor defect. Among the acquired defects, the three most important acquired defects of clotting factor are DIC, disseminated intravascular coagulation. Then you have liver disease, and you have vitamin K deficiency. Vitamin K deficiency. So these are the things that are really important. Apart from this, if they ask you what is the most common cause of acquired clotting factor deficiency, my answer would be liver disease. That is going to be the most common acquired clotting factor deficiency. Okay, leave the most commons. Anyway, that's not going to be of too much matter here. But if you take this congenital deficiencies, hemophilia A and hemophilia B, this factor VIII and factor IX, both are present on the X chromosome gene. Both are genes that are present on the X chromosome, which means these disorders are X-linked recessive disorders. What do you mean by the fact that these are X-linked recessive disorders? Which means they are going to affect males predominantly. Almost 95 to 100% of the affected individuals are going to be males. And severe disease means again it will affect only males. Females are unlikely to have severe disease. But what about the importance of females in X-linked recessive? As you all know, females tend to be carriers in X-linked recessive disorders. So that's the importance of females here. Apart from that, these disorders, especially this hemophilia A and B, do not have any particular geographical distribution or ethnic populations. They don't affect Asians or Chinese. There's no typical ethnicity or typical geographical distribution that is going to be seen in any of these hemophilia related disorders. Clear? All right. So we can see the mutations of factor VIII. So what are the genetic? I have to tell here. Maybe we can tell there are certain genetics that you have to know about the factor VIII. So let us see what are the types of mutations that you can encounter with factor VIII. 50% of the mutations tend to be of three types. That is missense type mutation, or frame shift type mutation, or it could be even a deletion of a factor VIII gene. So these are contributing to 50%. So the remaining 50% is going to be contributed by one specific and characteristic type of mutation called flip tip inversions. This flip tip inversion type mutations are so characteristic for factor VIII deficiency in hemophilia A, and these contribute to almost 50% of the remaining mutations of factor VIII. So usually this flip tip type inversion mutations generally cause disruption of the factor VIII gene, resulting in poor protein or poor quality or quantity of the protein secreted by the particular gene. So that's the reason, even though the mechanisms are not important how these flip tip inversions work, but still it's important to know the name at least, that is flip tip inversions. So with this basic understanding, let us move on to the clinical features of what will be the factor VIII deficiency or a factor IX deficiency. In general, let us see as a common clinical characteristic. First of all, you have to understand only 2/3 will have family history. 1/3 generally do not tend to have family history, which means it is suggesting these 1/3 of the patients who don't have family history may have developed the disease because of new mutations. Clear? Okay. Now let us move on to the classification and clinical severity and factor levels, maybe factor 8 or factor 9, doesn't matter, factor levels, and prophylaxis and treatment. Prophylaxis and treatment, so whether you will give it or not. So first one, you have something called a physiological factor levels, where there is no need to comment on clinical severity, at least 50% or more factor levels, and you don't need any prophylaxis for this. This tells you one important point, that 50% of the factor are enough for physiologic functions, which means your APTT normalization needs, in order for your factor tests like coagulation factor tests like APTT, PT, and all to be normal, you just need what? 50% of the factor activity. At the same time, not to produce any bleeding, just 50% of the factor activity is enough. So note that point. We'll be using that in the later period. And you have mild disease, where the patient will have bleeding only after severe trauma. Only severe trauma will cause bleeding, where the factor levels will be somewhere around 5 to 50%. And let us come to the prophylaxis in some time. Moderate cases, cases with moderate severity will have bleeding even after mild trauma itself, where the factor levels will be just 1 to 5% of the normal. And in these two disorders, where the disease or deficiency is mild or moderate, even the treatment, the prophylaxis needs to be highly individualized. It depends on the clinical characteristic as well as the bleeding characteristics of the patient. But remember, in exam, if they ask you for mild to moderate cases, we just treat with desmopressin. Desmopressin is the thing that is used for prophylaxis and treatment for mild to moderate cases of hemophilia, but heavily individualized. Again, it depends on the bleeding, characteristics of the bleeding, nature of the bleeding, and a lot of phenotypic and genotypic characters are there. That's what going to determine the treatment, but in exam you can answer it's a desmopressin as a treatment for mild to moderate case of hemophilia. How desmopressin works? Because desmopressin is going to increase the release of von Willebrand factor from Weber palate bodies in the endothelial cells. So once they release this von Willebrand factor doesn't only carry von Willebrand factor along with them, they also carries factor 8 along with them. So that is the idea. Simple. In severe disease, many of the times the patient may have a spontaneous bleeding where the factor activity will be less than 1%. Likely you have to use a continuous and regular prophylaxis with factor concentrates in these patients. That's the idea. That's what you have to do. So what are the clinical features that you will expect to see in a patient with a hemophilia, either A or B? So now we have seen the clinical severity, all right, but what are the features, what are the bleeding features you will see? Number one, as I told you, most often the coagulation factor defects tend to produce deep bleeds, deeper hematomas. Usually deep bleeding in the sense they will produce hematomas typically in the soft tissues. Very common soft tissue that goes for this hematoma is the muscle. And second thing they form is in the joints. And this joints developing this hematomas is also referred to as something called hemarthrosis. Very, very, very typical of your clotting factor deficiency. Number two, they can produce ecchymosis in the skin, and this ecchymosis tends to be very, very huge, very big, and usually single, and they are palpable. And they are limb spanning ecchymosis, which means the entire limb may be affected with this ecchymosis. Single ecchymosis spanning the entire limb. Very characteristic again. Apart from that, usually after trauma or a surgery, very commonly they get delayed bleeding. That is what is characteristic of a coagulation factor deficiency. Delayed bleeding is very characteristic after a trauma and a surgery. Delayed bleeding, very, very characteristic. Typically mucosal bleeding and organ related bleeding. Like mucosal bleeding means I'm talking about your gastrointestinal and genitourinary bleeding or intracerebral hemorrhage are generally quite rare in coagulation factor deficiency, but still can happen. It's not like it cannot happen, still can happen, but generally rare in clotting factor deficiency. So in general, many of the patients will have these features only. These deep hematomas are highly, highly characteristic, and the ecchymosis are very, 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 very characteristic of coagulation factor deficiency. So these are things that you have to know about the clinical features. At the same time, these hematomas which I told you, which happen chronically, or if it is happening recurrently, if it's happening chronically and recurrently, they can give rise to a very, very peculiar clinical feature called as a hemophilic pseudotumor. What do you mean by hemophilic pseudotumor? For example, if there is a bleeding that is happening continuously for a long time and recurrently for a long time, for example, if you take a muscle forceps, the area that is filled with this bleeding will start undergo cystic changes. That is because of reabsorption of this bleeding in certain areas with lot of mixed echogenesis will be there. So a lot of places will go for cystic changes. At the same time, this is due to chronic bleed. Clear? And it will become highly encapsulated. And they will have in between cystic changes as well due to resorption of the blood. And new bleed also will come, and so that it will become a messy kind of a thing over there. If it's affecting the bone, suppose if you see this same kind of continuous bleeding in the bone, these changes also will be seen. The cystic encapsulated kind of thing changes will be seen. Plus at the same time, you might also have osteolysis in that area, that is bone loss in that particular area. Plus at the same time, you might also get reactive new bone formation. Reactive new bone formation, that is osteosclerosis in the surrounding zone. Reactive new bone formation. Clear? So these are the things that are going to happen here. So these are the things that you are going to get. So this is what we refer to as something called a hemophilic pseudotumor. So let us see an image here. So what you are seeing here is this is a young boy with a typical hemarthrosis, acute hemarthrosis of the right knee. You can see it as swelling, or this is very difficult to spot. This could be septic arthritis also, but how will you tell it's a hemarthrosis is when a patient with a hemophilia comes with this joint, type of a joint. Characteristically, I will take this patient as a hemarthrosis for sure. And you can see this is a large single solitary ecchymosis that is seen on the buttock area. And what you are seeing here is this is called the hemophilic pseudotumor. This is what we refer to as something called a hemophilic pseudotumor, where you can see a lot of areas where blood is absorbed, and you can see a lot of areas which is also having a fresh bleed. So this will produce a mixed echogenic area. So it will look like typically a mass lesion or a tumor. So that's what we refer to as something called a hemophilic pseudotumor. And in comparison, you can see a normal area on the other side, and you can compare with this what you have seen previously. So and you can find the difference easily. So this is what we refer to as hemophilic pseudotumor. Clear? We can also see some more images in this particular hemophilia group, where you can see a patient who is having a destroyed joint due to chronic hemarthrosis. Due to chronic hemarthrosis, you get an arthropathy, and the evidence of arthropathy you can see here. This is you cannot see the joint line at all. The joint line is completely narrowed, and you can see a lot of osteosclerosis, and it's a completely destroyed joint. So this is called hemophilic arthropathy, very, very common entity. And this is another example of a hemophilic pseudotumor, where you are seeing a cystic mass-like lesion here with surrounding osteosclerotic lesion, which is producing a mass-like appearance. So this is also one example of a hemophilic pseudotumor. Clear? So these are some of the important clinical images that you have to know as far as hemophilia is concerned. Clear? So you have different types of prophylaxis. There are two things are there. Prophylaxis and treatment are usually interlinked as far as hemophilia is concerned. So let us see what are the types of prophylaxis you do in a hemophilia patient. So you have three types of prophylaxis. One is called an episodic or on-demand prophylaxis. Second one, you have an intermittent or a periodic prophylaxis. Intermittent or a periodic prophylaxis. Third one is something called a continuous or a regular prophylaxis. Clear? So whenever you think about an episodic or an on-demand prophylaxis, what we do typically here is we give replacement factor only at the time of bleeding. Only at the time of bleeding. Only if the patient bleeds, that time you will give. If you have intermittent, what do you mean by intermittent or periodic prophylaxis? Means we give only at the time of high risk of bleeding. High risk of bleeding. That too only for a limited period. We don't give continuously. Typical example of a high risk timing for bleeding is surgery. especially after surgery, it's a high risk for bleeding. So if you give only for a transient period, temporarily for some time, that only to prevent this bleeding, that is called intermittent or periodic prophylaxis. If you give continuous prophylaxis, means you have to give continuously throughout the life. That is called continuous or regular prophylaxis. But in continuous or regular prophylaxis itself, there are three types. One is called primary continuous, secondary continuous, and tertiary continuous prophylaxis. What do you mean by primary continuous prophylaxis? If you give within 3 years of age, or if you are giving before the onset of second large joint bleed, before the onset of second large joint bleed, or before the onset of second hemarthrosis. Remember, the idea behind that is the first hemarthrosis may be sometimes you don't know why it is happening. Because if you don't know the patient is suffering from hemophilia, they come with the joint swelling, and you take the aspirate and see it's a bloody joint, and you confirm it's a hemarthrosis. You suspect a coagulation factor deficiency, and you confirm it's a hemophilia now. Now what you will do? You have to prevent the next joint bleed. That's why I'm telling, in a patient who don't know the diagnosis, when they present with hemarthrosis, if you start the prophylaxis to prevent the next joint bleed, that also comes under primary prophylaxis only. Or if you already know the patient that is suffering from, he or she is suffering from hemophilia, the child is suffering from hemophilia, you have to start ideally within 3 years of age. That is what we define as again a primary prophylaxis. Clear. So what do you mean by secondary prophylaxis? Secondary prophylaxis, if you start after at least 2 large joint bleeds, clear, but before the development of arthropathy. The patient has not developed hemophilic arthropathy, with the picture we have seen already. So here, tertiary prophylaxis means you are starting the prophylaxis after the onset of arthropathy. That is what we refer to as tertiary prophylaxis. So these are the types of prophylaxis you have. Just the definitions are important. Apart from that, it's not that important. So diagnosis wise, how we want to do is by seeing first of all clinical picture. The clinical features may be suggestive of a clotting factor disorder, which means the typical clinical picture of hemarthrosis, massive ecchymosis and hematomas can be there, which will make you do APTT, PT and INR. In this, typically in hemophilia, you will have a normal PT and INR, because these are going to test the extrinsic and the common pathway. So here in hemophilia, extrinsic and common pathway are normal, so this is supposed to be normal. So what you will see instead is the elevated APTT, because APTT is a measure of an intrinsic pathway and a common pathway. In hemophilia, the problematic thing is the intrinsic pathway, that's all, not even the common pathways. That is the reason why APTT is elevated. So when you see a clotting factor disorder like clinical feature, when APTT is elevated, isolated elevation of APTT, there are 2 DDs are there. One, it could be a clotting factor deficiency, or it could be a clotting factor inhibitor that is circulating. What are clotting factor inhibitors? These are nothing but antibodies that are circulating in the blood that inhibit the clotting factors, any clotting factor. But the most common clotting factor that against which these antibodies are generated is again factor VIII. But it can be against any clotting factor. But most commonly, the inhibitors will be developed against factor VIII due to unknown reasons. Okay. So how will you find out whether it's a clotting factor inhibitor or a clotting factor deficiency? You have to do some testing called 50-50 mix, or 50-50 mix study, or 50-50 study. What do you mean by 50-50 mixing study? You take 50% of the patient's plasma, half of the patient's plasma, and remaining half of that particular reaction will be contributed by a normal plasma. This normal plasma, let me write normal plasma. So this normal plasma you will be taking from pooled donors, obviously, like FFP. From a pooled donor, you take this normal plasma and mix. Because the idea is, if it's a factor deficiency, this normal plasma will provide the clotting factors. Do remember the fact I told you, APTT can be normal if just 50% of the clotting factors are normal. If you just have activity of 50% clotting factor activity is intact in the plasma, your APTT will be normal and there will be no clinical features. That is the principle you are going to use here. So 50-50 mix, at least 50% you are providing normal clotting factors, and see the APTT again. If APTT is corrected, or APTT is still not corrected, uncorrected. If APTT is corrected, you are going to call it as a clotting factor deficiency, because the moment you provide normal clotting factors, at least 50% of clotting factors of normal plasma, the APDT gets corrected. That is means it's a clotting factor deficiency. You are supplementing by normal plasma and it gets corrected. If it's not corrected, then which means there is a clotting factor inhibitor, because these antibodies will inhibit the clotting factors present in the normal plasma also. So there won't be any correction. So this is a very important point, 50-50 mix. Apart from that, what are the other things you have to do? You have to prove the patient is not having von Willebrand disease, because certain types of von Willebrand disease like type 2B, type 2N and all, they might mimic a hemophilia, literally. So that is why you have to do the von Willebrand factor antigen levels, which will be decreased in von Willebrand disease, but here it will be normal. Then you have to do something called von Willebrand factor 8 binding assays, because there are some types of von Willebrand disease where you might have a poor binding to factor 8. That is the reason for developing hemophilia like disease. So that also should be normal. Factor 8 von Willebrand factor binding assays, which will be actually normal. But here the hemophilia problem is deficiency of factor 8 only. But the binding assays and all will be normal. Since von Willebrand factor can bind with the factor 8, no problem. That and all is not a problem. Then you have to rule out platelet disorders, platelet dysfunction, just for namesake, which can easily prove that telling that PFA 100 is normal. To confirm that is a clotting factor disorder, you can tell factor 8 or factor 9 levels, activity that will be decreased. That also we can prove. So these are the ways of diagnosis. Then let us move on to the treatment aspect. Treatment. So what are you going to do then? Treatment. Treatment, two types of things are there. You can do as a prophylaxis, where you have to know what you mean by continuous and regular prophylaxis, and what are the indications for continuous and regular prophylaxis. Second thing, what you have to know is what will you do in times of bleeding. Suppose despite giving prophylaxis, the patient develops bleeding, or the patient is not having prophylaxis but develops bleeding, what you will do. So indications for prophylaxis is all patients with severe hemophilia, severe disease, which means whenever the factor activity is less than 1%, all of these individuals should receive a continuous prophylaxis, no matter what. And typically what we are going to use is factor concentrates. I'll tell you what are the different products available for factor concentrates, but still factor concentrates are the ones we are going to use. And the dose, like when I am going for hematology water rounds, they ask this dose routinely. I don't know why. They tend to ask this very, very routinely. There are two protocols are there for dosing. One is called the Malmo protocol, and second one is the Utrecht protocol. Malmo protocol tells you have to give 25 to 40 units per kilogram of factor concentrate, and Utrecht protocol tells a little lesser dose is still effective, 15 to 30 units per kilogram factor concentrate. And the only thing that you have to know is, even though the doses are different, but if it's a factor 8 deficiency or a factor 9 deficiency will determine the dosing interval. If it's a factor 8 deficiency, you have to give 3 times per week, whereas if it's a factor 9 deficiency, you have to just give 2 times per week. Why factor 9 deficiency alone is 2 times per week? Because the half-life of factor 9 is very high. That is the reason they can circulate for a longer time, and that's also the reason why we give only 2 times per week for factor 9. But factor 8 you need 3 times per week transfusions. And ideally when you should start, we should start within 3 years of age for continuous or regular prophylaxis, but ideal time for starting the prophylaxis is within 1 to 1.5 years. Clear? As a primary prophylaxis, ideally. That's the ideal one. And it has to be given at least for 85% of the year. If the moment you decide it's a continuous prophylaxis, give at least for 85% times of the year, which means at least for 45 out of 52 weeks in a year, you have to keep transfusing. 7 weeks you can give a holiday, but still as much as possible try to give all 52 weeks. That's the idea. But you can give a holiday of approximately 7 weeks in a year. But 45 weeks the patient should receive transfusion minimum. Factor 8 concentrate. Bleeding. So in times of bleeding, how will you treat? In times of bleeding, again it depends on the type of bleeding. If it's a life-threatening bleeding, or if the patient is suffering from a head injury and the patient is a hemophilia, or if it's an intracerebral hemorrhage. In these conditions, you have to maintain the factor levels of at least 80 to 100%. But for exam's sake, you can remember 100% of the factor levels has to be maintained. But what is the idea of giving a prophylaxis? For giving a continuous prophylaxis, you have to maintain factor levels of at least 1 to 2%, which is the idea is to prevent spontaneous bleeding at least. And to maintain a good quality of life, to prevent at least hemarthrosis, you need this 1 to 2% level has to be maintained. So that is the idea of giving regular prophylaxis. But for bleeding, during times of bleeding, especially life-threatening bleeding, you have to maintain factor levels at 100%, not 1 to 2%. So typical dose needed for maintaining this particular 100% factor activity is, if it's a factor 8, you will give 50 units per kilogram dose, and if it's a factor 9, you are going to give 100 units per kilogram dose. Or if it's a minor bleed or other bleeds like joint bleed, or if it's a minor surgery. Here obviously major surgery is a form of like life threatening only, but minor surgery or a minor bleed or a hemarthrosis, here you have to maintain the factor levels at 50% at least, and the dose needed for that is, for factor 8 you give 25 units per kilogram, and factor 9 you are going to give 50 units per kilogram. At the same time, how long you have to maintain this 100% levels? At least for 10 to 14 days. How long you have to maintain this 50% factor levels in minor and other bleeds? At least for 3 to 5 days. So these are some of the questions that you might be asked. Clear? And next, let us see the products that are available for factor 8 and factor 9. For factor 8, there are certain products available, and for factor 9 also you have certain products. For factor 8, you can split into something called intermediate purity and high purity. Intermediate purity factor 8s are not, factor 8 concentrates are not used right now. One of the important examples of intermediate factor 8 concentrate is Humate-P. Even though it's not used, you can ask me why you are telling them. This Humate-P is actually a very notorious thing. Why? Because this Humate-P is well known for the fact that it has transmitted a lot of HIV, hepatitis B and HCV cases in the 1980s. It's abandoned anyway, it's not used, but it's actually still embedded in the history because of this notorious, example of transmitting a lot of HIV and HBV, HCV cases during the 1980s through hemophiliacs, through blood, through these factor 8 concentrates. So that's why this is important, this Humate-P. Then apart from that, you have recombinant factor 8s also. Recombinant factor 8 also. In that you have first generation, you have second generation and third generation recombinant factor 8. First generation recombinant factor 8 is called recombinate, which typically contains albumin. That's why we don't use it right now, because they contain albumin. Second generation is also referred to as something called helixate, and the third generation we call something called an advate. Advate does not contain albumin. Clear? This is the advantage, so that's why we prefer this one. And the newer one is there, that is called Eloctate, ELOCTAT. Eloctate is a newer one. This Eloctate is currently preferred one because this is a factor 8 with the FC fusion, which means they would have fused with FC fragment of the immunoglobulin. Why we do that is to increase the half-life, to increase the stability and increase the half-life, because now it becomes approximately 4 days from 1 day. So to increase the half-life, so the number of doses can be reduced. That's the advantage of Eloctate. So this is upcoming recently in India also. So factor 9 only 2 are there, but not important for exams. One is called Rixubis and second one is called Alprolix. In India only Alprolix is available by Novartis, but Rixubis is not available in India. But Alprolix, yes, it's available, but very, very costly. So at least this Humate-P you can remember just for the sake of history, because it has transmitted, it's been reason for for many of the deaths of hemophilia patients due to HIV and hepatitis B. Okay. Then what are the other options for these hemophiliacs? Other treatment options that you can use is, number 1, desmopressin. Typically used only for mild cases of hemophilia. Second one, epsilon aminocaproic acid and cryoprecipitate. This epsilon aminocaproic acid is a inhibitor of fibrinolysis. That's the reason why we use for treatment of bleeding. At the same time, this cryoprecipitate we use only as adjunctive therapy. These are not mainstay of therapies. During bleeding, you can use as an adjuncts. That's all. Number 4, there is a new drug called emicizumab is there. So it's a mAb, which means it's a monoclonal antibody. So what this emicizumab is going to do? So in what way? This could be definitely a very, very, very important potential question for your exam. So what emicizumab does? how it works. Emicizumab is one of the best examples of how much advances we have right now. It's a bispecific antibody. It also tells you how beautifully I've understood the pathology and physiology. I mean, how the scientists have understood beautifully. I mean, not us. Us reading is very simple because we are reading someone else's research. For that itself, we are feeling it's difficult. But these scientists are the real heroes who have really found out what's the mechanism that's really happening through mind-boggling researches and investigations. I don't want to go about that. Anyway, so Emicizumab, they are the real heroes. First, trust that. So Emicizumab, how it works is, first you have to understand how the factor 8 works. I told you factor 8, activated factor 8, let us assume, I can put like this. Let us put this an activated factor 8, and it works like a cofactor. So how it's going to work like a cofactor? Because it's going to bring the two factors with each other. The first factor, let us assume this is a factor 9 in activated form, 9A, and you have factor 10 in activated form, that is factor 10, and this factor 8, activated factor 8, is going to bring this factors together so that I can draw something like this. And it's going to form a scaffolding like this, and they are going to bring the factor 9A and factor 10 together, which means it's the one that forms as a cofactor and forms the basis of the reaction site. Now only the factor 10 will become activated because of this reaction, which means this factor 8 is going to act as a cofactor. And this is what we are going to use in the Emicizumab mechanism. What Emicizumab does is, Emicizumab acts like a factor 8A, which means it's a bispecific antibody. On one end, it's going to bind with factor 9 activated fragment, and on the other end, it's going to bind with factor 10, which means it also brings both the factors together, and they form the reaction site, and they produce activated factor 10, which is a common pathway, and downstream it's going to activate fibrinogen and thrombin. Do you understand? As simple as that. So Emicizumab is going to mimic your factor 8A action. It's a bispecific antibody. On one side can bind with factor 10, and on side can bind with factor 9. Superb. And remember, this Emicizumab is one thing that is useful for treatment of hemophilia patients, both with and without clotting factor inhibitors. I'll tell you what is the nick in that, why I told you that point specifically. Okay, now let us see patients who develop factor 8 inhibitors. What do you mean by factor 8 inhibitors? Remember, let me tell you an example. If you have a patient with a severe hemophilia, for example, if you have a patient with a severe hemophilia, which means there are no factor at all in them, which means there is no factor 8 at all. Leave the factor 9 for now. Tell the factor 8 only. There is no factor 8 in their blood circulating, which means their body has no idea about what is factor 8. Suddenly you are infusing factor 8 concentrates. After the moment you diagnose, it's a hemophilia. And there is a lot of chance that your body might think this factor 8 that you are infusing for the first time in their entire life, the body sees the factor 8 for the first time, they might consider it an antigen, and they start developing antibodies against factor 8. So this is one of the most common mechanisms how you develop this acquired factor 8 inhibitors. So which means these are acquired, not inherited. It develops approximately in 30% of severe hemophiliacs. In almost 30% of severe hemophiliacs, you develop this acquired factor inhibitors. 30% of severe cases. I'm not talking about mild to moderate. So mild to moderate case at least has some amount of factor 8 which is already there. So no point in forming antibody. 30% of severe hemophiliacs, this might be recognized as a new antigen. They might form antibodies against factor 8. And if they form antibodies, it will be formed within 50 days of exposure. Generally within 50 days of exposure, they form these antibodies. The problem with this factor 8 inhibitors is, the moment you develop these factor 8 inhibitors, your factor 8 concentrates become completely ineffective. Now your factor 8 concentrates, if you start transfusing, they will become ineffective in the presence of antibodies, because these antibodies are going to bind with the factor 8 whatever you are infusing, and they are going to neutralize the factor 8, and factor 8 will not be used for coagulation. Instead it will be neutralized by these antibodies, inhibited by these antibodies. Clear? Apart from the hemophiliac, you can also develop this acquired factor 8 inhibitors in postpartum women, especially who are multigravida. and in certain patients who have background autoimmune disorders or myeloproliferative disorders or any lymphoproliferative disorders, because these two conditions will generate abnormal antibodies with different specificity. So probably autoantibodies may be produced in this. So that is the reason they can develop as an autoantibody. They can develop antibodies against your factor VIII itself. So what are the potential options for treatment if you have a factor VIII inhibitor? I told you how to demonstrate this factor VIII inhibitor. Diagnosis wise, you have to see APTT, which will be increased and uncorrected with 50-50 mix. This is a very important thing. This is what is going to tell the presence of a acquired clotting factor inhibitor, and you are going to find out this through amount of factor VIII inhibitors that are present in the circulation through something called a Bethesda titer. But remember, this 50-50 mix non-correcting the APTT is a classic gold standard for diagnosing a factor inhibitor that is circulating in the blood. So what are going to be the treatment? So now your factor concentrates are not working. So you have a lot of options, smart options are there. For example, factor 7A concentrates you can use. The good thing about factor 7A concentrates is because it's going to work by extrinsic pathway. So remember, factor 8 works via intrinsic pathway. 8 is going to work by intrinsic pathway, which you don't have, we already told, because of the inhibition of the factor 8 by a factor 8 inhibitors. But if you increase the levels of this active factor 7, they can directly activate factor 10 to 10A, and you can enter the common pathway, which is going to further activate prothrombin to thrombin and fibrinogen to fibrin. So the idea of giving this activated factor 7 is to bypass this intrinsic pathway and to form the coagulation only via the extrinsic pathway. But the problem with this is this factor 7A concentrates have an extremely low T half, and there is like a need for multiple transfusions, very repeated transfusions you have to do. So that is one big problem with that. And second thing, you can try high dose factor 8, but that is successful in some patients but not so successful. A very reliable option is for something called FAIBA. FAIBA, that's called factor 8 inhibitor bypassing agent. That's called FAIBA. So it is nothing but a 4-complex PCC, what you have used for warfarin induced bleeding. It can be used for vitamin K deficiency induced severe bleeding also. That's called 4-complex concentrate. Clear? 4-complex PCC, prothrombin complex concentrate. What they have is, they have this factors 2, 7, 9, 10, which is the prothrombin complex. They are going to have this prothrombin complex in an activated form. It's called an activated prothrombin complex. It's called an activated prothrombin complex. They are going to have this factor 2, 7, 9, 10 in activated form, which means it's going to completely rely on the extrinsic pathway. You can see here, so you have initially this factor 7 in activated form will be there. It also has factor 10, which will be easily activated by already present activated 7A, and 10 also is there in this particular complex. So 10 will be activated 10A, and immediately prothrombin is also there in this particular PCC. So immediately your 2 will be activated 2A. Then finally, since all these factors are already there, you have 10 and 7. So this is a complex that will be present. So this is the factors that are present in this PCC, 4-complex PCC. So since all these are already present, you are ready-madely forming this thrombin. Thrombin is formed in a ready-made manner, and this thrombin directly is going to activate the fibrinogen to fibrin. Which means what I am trying to tell is, all this will already be there in the product, and the only thing after infusing this product will just convert the fibrinogen to fibrin. That's all. So that is why this product completely bypasses your intrinsic pathway. There is no need for intrinsic pathway at all. Clear? So that is the reason why this is a major thing. This is one of the very important thing that's called FAIBA. That's factor 8 inhibitor bypassing agent. And it also has to be, to an extent, it also has factor 9. Clear? So which can itself form this factor 10 to an extent. So this is what we refer to as factor VIII inhibitor bypassing agent. Clear? Which means it completely bypasses the intrinsic pathway and it works only via extrinsic pathway mechanism. So the only thing that the moment you give this product, this will directly convert the fibrinogen to fibrin and there is nothing else needed. So thereby establishing hemostasis. But it's a very, 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 very costly drug. It's not a very cheap drug like what you think. It's very costly. According to me, I think it costs around 60 lakhs per unit. Too costly. Clear? So what are the other options? The modern option is emicizumab, which doesn't work by your factor VIII mechanism at all. It mimics factor VIII, but it's like a monoclonal antibody mimicking a factor VIII action. So emicizumab can work in patients with or without factor VIII inhibitors. So it doesn't matter. That's why I told you that point is important. And once the bleeding is controlled, you have to start immunosuppression because you have to down-regulate these antibodies. So you can use some immunosuppressive agents like steroids, cyclophosphamide or rituximab, which reduces the production of antibodies from the B cells. At the same time, if the patient is having acute bleeding, you can use intravenous immunoglobulin or plasma exchange, therapeutic plasma exchange. After giving this, IVIG plasma exchange is given to remove all the antibodies that are circulating in the blood. So once you remove the antibodies that are circulating, now if you give factor VIII concentrates, then it will work. So IVIG or plasma exchange is for urgent treatment. So urgently you can give and reduce the antibodies immediately and you can start the factor VIII concentrate therapy. This steroids and cyclophosphamide rituximab are for chronic maintenance therapy to suppress the antibody production in a chronic basis for a long time. So that is what the mechanism of action of the steroid, cyclophosphamide and rituximab. Clear? So this is how they are going to work. So these are all beautiful mechanisms which you have to know. Then there are two other factor deficiencies which I have not discussed. One is called factor 12 deficiency. What are the features of factor 12 deficiency? There will be elevated APTT. Definitely it corrects with mixing. At the same time, they will have a normal PFA 100, normal platelets, and normal PT and INR. Clear? All this will be normal. But most importantly, this factor 12 deficiency will not cause any bleeding manifestation. Absolutely, patient will be asymptomatic. It's a true isolated elevation of APTT. Clear? Very important point. No bleeding. So this is factor 12 deficiency. What about factor 13 deficiency? This is also referred to as fibrin stabilizing factor, which is the one that converts the monomers of fibrin to like fibrin meshwork polymers. So they cross-link the fibrin. So this factor 13 is very, very important, which is activated by thrombin again. It's a thrombin dependent factor. So here you will have again elevated bleeding incidences. So what will be the typical bleeding type in these kind of patients with factor 13 deficiency is delayed umbilical cord bleeding, delayed umbilical cord or stump bleeding. Delayed umbilical cord, stump bleeding. Very, very important point. So this is the gold standard. If you get this in any of the exams, you have to answer factor 13 deficiency. Clear? And many times you will get a delayed post-op bleeding. That is what they might give, but the delayed post-op bleeding is also a feature of other clotting factor deficiencies. But this delayed umbilical cord bleeding is so characteristic, and delayed umbilical cord stump bleeding is so characteristic of your factor 13 deficiency. And do remember here, then APTT also will be normal. APTT will be normal, PTNR will be normal, PFA 100 will be normal, platelet count will be normal. But still the patient will exhibit this delayed umbilical cord or stump bleeding. Very characteristic. Why they have normal APTT, PT and INR? Because I told you, you have intrinsic pathway which ends up with factor 10. And again you have extrinsic pathway which is through 7A, and again it ends up with factor 10. Factor 10 activates factor 2, factor 2 activates fibrinogen to form fibrin. And this fibrin will form clots and stable, polymers of fibrin, or you can form a meshwork, fibrin mesh. And to form this fibrin mesh, you need this factor 13 in a nutshell. Remember, your PT-INR measures extrinsic pathway and common pathway. PT-INR. Remember, this 10 is what we refer to as common pathway, maybe up till 2, that's all. And your intrinsic, your APTT is going to measure intrinsic and the common pathway. But remember, once the fibrin is formed, you don't have anything to measure actually. You don't have any this PT-INR or APTT-INR, because all this measures the formation of fibrin only. Your PT-INR measures the formation of fibrin from thromboplastin. Your APTT measures formation of fibrin from addition of phospholipids and calcium. So all are going to measure till the fibrin only, formation of fibrin only. They don't measure this factor 13 activity. That is the reason why PT, INR, APTT, all these things tends to be normal in this condition, factor 13 deficiency. So how will you diagnose this factor 13 deficiency is a $1 million question. We are going to use something called a urea clot lysis time. Urea clot lysis time. So what do you mean by urea clot lysis time? Typically, if you add a urea to the clot, for example, there is a clot, this is a clot formed here, already clot is formed, and if you add a 5 molar solution of urea, so now I am adding a urea, this is a 5 molar urea solution, and this urea will slowly start dissolving the clot. If the fibrin meshwork is stable, it takes at least more than 24 hours to dissolve the clot. Suppose if it dissolves within 24 hours, which means the fibrin meshwork is defective, and that is suggestive of a factor 13 deficiency. That's the idea. So if they ask you what test you will do for factor 13 deficiency, you have to go for urea clot lysis time, not PT, APTT or INR. Remember, factor 12 deficiency is going to have no bleeding, but they will have a significantly elevated APTT. But whereas this factor 13 deficiency will have bleeding, especially the delayed umbilical cord bleeding, but they will have a normal APTT, PT and a INR. Then finally you have factor 11 deficiency. Factor 11 deficiency, this is also referred to as hemophilia C. This could be a question in exam, but anyway, many standard textbooks don't give this, but typically it is also referred to as something called hemophilia C. And it's autosomal recessive. That is also very important, because many clotting factor deficiency you saw is X-linked recessive. This is autosomal recessive. And very characteristic is they are associated with something called slow oozing, typically from mucous membranes. And this usually mimic a bleeding disorder. That's why this is special. Slow oozing from mucous membranes, especially after a gastrointestinal, genitourinary or a ENT side. And this oozing typically follows a minor surgery, minor trauma or minor surgery. And definitely, since it's a part of the intrinsic pathway, your APTT will be surely elevated without a doubt. And treatment wise, you can use only FFP. There are no factor concentrates, because it's such a rare disease, you don't have factor concentrates for this. No company is going to sponsor. But this slow oozing from mucous membranes following minor surgery in these sites, for example, tonsillectomy producing a slow oozing. What do you think? You think of von Lebrun disease. Don't think of this. That's what I'm telling. In exam, usually they will ask about von Lebrun disease. If there is a slow oozing after tonsillectomy, means it's von Lebrun disease. I don't know why. It's a stereotypical question. But anyway, you can think about this. Hemophilia C, that is factor 11 deficiency also, just for information. That's it. I don't think this question will be asked. Okay, then you have acquired clotting factor defects. What are the acquired coagulation disorders? The first acquired coagulation disorder is going to be on DIC, that is disseminated intravascular coagulation. So what do you mean by disseminated intravascular coagulation? First of all, DIC is a type of a TMA, that's called a thrombotic microangiopathy. And these TMAs follow a typical triad. So what is the typical TMA triad? That's a microangiopathic hemolytic anemia. The important evidence of this microangiopathic hemolytic anemia is the cystocytes in the peripheral smear. And you have intravascular hemolysis that will result in very, very high level LDH elevation, and there will be very much reduced haptoglobin levels because they capture the free hemoglobin. And there will be hemoglobinuria, hemosideриnuria, and all this stuff, which we are not going to discuss. Already we have discussed enough. Then they are going to have thrombocytopenia. Then they can also have end organ failures. These end organ failures can be either kidney or brain or even GIT. Any end organ can fail. This is a characteristic TMA triad. It can be seen in many conditions. The moment you see this TMA triad in exam, the classical DDs are only two. One is HUS TTP complex, or it could be a DIC. But a lot of other things like even accelerated scleroderma, that scleroderma renal crisis or malignant hypertension, all these things also can mimic your TMA picture. But anyways, these are the classic DDs in exam that you have to know about TMA. The differentiation comes from two things. You do a D dimer, PT, APTT, INR and all the coagulation profile. If all these are elevated, if all these are normal. If all these are normal, I will be typically thinking about HUS TTP complex. Very important. Further differentiation will be based on other investigations. So you are going to evaluate, which we will discuss later on in nephrology section. If they are elevated, this is what is going to give a diagnosis of DAC. So that is why this elevation of D dimer is such an important aspect in a diagnosis of a DAC. So let us see why the D dimer, PT, APT, INR, all these things are elevated. PT, INR, APT, INR is variable, but anyway. So that will be usually elevated as far as the exams are concerned. So this is going to give a diagnosis of definitive DAC, surely. If you have a TMA triad with this elevation of D dimer. Clear? So this is DIC. So what are the etiologies of DIC? Now let us see what could be the etiologies of DIC. The first one, number one, you have to always tell sepsis. Whatever causes I'm going to tell in the future doesn't matter. Sepsis remains the topmost cause of DIC even now, and typically due to gram-negative sepsis, endotoxic shock. And a lot of other infections also can cause. Apart from that, there is an organism called Clostridium welchi. It's a gram-positive organism. That's why it's very important. Still, it can cause a DIC. And you can get with severe falciparum malaria, and you can get with certain viral infections like HIV, CMV, varicella virus, and all these things. Apart from that, lot of malignancies can cause DIC. One of the important malignancies that cause DIC in exam, they will always ask you about this AML M3. 10 to 20% of the case of AML M3, that is acute promyelocytic leukemia, are going to present with DIC. Very important. Maximum number of wire rods, maximum number of maximum MPO and Sudan black positivity, and maximum DIC incidence. All these things goes towards AML M3 among all the subtypes of AML. Second one, lot of gastrointestinal adenocarcinomas like pancreatic cancer, stomach cancer, lot of things can cause DIC as a presenting feature. Then lot of obstetric complications are there which can produce DIC, like your septic abortions, amniotic fluid embolisms. All these things itself can trigger DIC. And severe trauma, especially major trauma, and conditions that cause severe systemic inflammatory response syndrome, all these things can cause DIC. Severe SIRS means you can get with acute pancreatitis, severe burns. All these things are going to cause severe SIRS, and that itself can result in a DIC. And next thing, you can get in mismatched transfusions. Mismatched blood transfusions can result in DIC, and extremes of temperature like hypothermia also can cause DIC, and even a heat stroke can cause DIC. And finally, in India, you should never forget about snake bite, snake venoms. All these things can cause DIC. Clear? In that, the most common cause definitely it's sepsis, but exam cause is always AML M3. Please do not forget. Never ever forget this AML M3. Very, very important for exams. Clear? What is the pathogenesis? Pathogenesis is due to a cytokine storm which is damaging the endothelium. Because of severe damage to the endothelium, there will be overwhelming activation of clotting pathway, coagulation pathway. It overwhelms the control mechanisms. It's too much of activation, it gets out of control. So too much activation of the coagulation pathway, and it's going to result in thrombosis. Typically microvascular thrombosis. Because of too much activation of coagulation pathway, there will be clotting factor consumption. Because of the clotting factor consumption, your lab reports will show elevated PT, APTT and INR. At the same time, They can even precipitate bleeding. So remember, this is one disease that has microvascular thrombosis with bleeding. Remember, macrovascular thrombosis with bleeding, you can think about heparin-induced thrombocytopenia sometimes. But this is a microvascular thrombosis. You won't get a DVT or a pulmonary embolism typically. You will have a microvascular thrombosis, not a macrovascular thrombosis. And thrombosis typically causes this end organ dysfunction because of hypoperfusion. End organ dysfunction and failure. So that's what is all about DIC. And this thrombosis also is going to activate the fibrinolytic pathway. Fibrinolytic pathway. Since they activate the fibrinolytic pathway, you are going to have elevated D-dimer and FDP levels. So this thrombus also consumes platelets, and this is the reason why these patients are going to have thrombocytopenia. So everything as explained. I told you why you get a thrombocytopenia, why you get an end organ dysfunction, why you get elevated D-dimer, why you get bleeding also sometimes, and why you can get elevated PDT-ANR. So this elevated PDT-ANR and bleeding is due to clotting factor consumption. That is the reason this DIC is also referred to as one traditional name called consumptive coagulopathy. Consumptive coagulopathy. It's a very old name. It's a very trivial thing that's given in a lot of pathology textbooks, which is easily understandable. Okay. And what are the compensatory mechanisms that you will develop? Since a lot of clotting factors are consumed and the levels of clotting factors are decreasing, as a compensation, what happens is, in a chronic DIC, your clotting factor production will increase. At the same time, your platelet production from the bone marrow will increase. Clotting factor from the liver will start increasing and the platelet production from the bone marrow will increase, which means in a chronic DIC, you might not see this thrombocytopenia and you might not see this elevated PTA-ANR and bleeding. You might be having only microvascular thrombosis and elevated D-dimer and end organ dysfunction. These three only will be there in a chronic or a compensated DIC. You might not have a thrombocytopenia or a elevated PTA-ANR and INR. So that's about the diagnostics. The moment you want to diagnose a DIC, the first thing you have to know is the clinical history, which means DIC is always secondary. There will be definitive underlying cause of a DIC, so that you have to know for sure. Second, if it's an acute DIC, definitely D-dimer will be elevated and your platelet will be low and your PT, APTT, INR, all this clotting factor investigations will be abnormal, deranged, it will be elevated. Suppose if it's a chronic DIC, again your D-dimer will be elevated because of ongoing thrombosis, but remember platelet levels and PT, APTT, INR values are highly variable, which means they can be normal sometimes. Only D-dimer elevation you will see. Apart from that, acute or chronic DIC, you will definitely see in peripheral smear there is something called cystocytes, that is due to microangiopathic hemolytic anemia. And again here I didn't tell you, again the thrombosis is the main reason why you get this MAHA, because microvascular thrombosis, this RBC has to move towards these small clots and they get sheared and teared up while moving, and that's the reason for microangiopathic hemolytic anemia, and they can produce cystocytes. Cystocytes generally do persist in chronic DIC also. But remember, in a chronic DIC, platelet values and PT-APTT INR values are unreliable. They may be normal. So that's a very important point again, because of compensation from the bone marrow and the liver by increasing the production of clotting factors and the platelets. So treatment-wise, treatment of underlying cause is the most important thing. The most important thing, treatment of the underlying cause. At the same time, you can consider platelets and FFP transfusions. FFP, typically the target is your fibrinogen. Target fibrinogen should be more than 100 milligrams per deciliter. If it's already in this target, no need to give FFP or cryoprecipitate. Otherwise, you can prefer FFP or a cryoprecipitate also. Clear? Then vitamin K deficiency. Lot of reasons are there why you get a vitamin K deficiency. Let us see the etiologies first. First one is the malnutrition. Malnutrition, which is quite rare anywhere in the world as of now. And second is reduced absorption of vitamin K. Reduced absorption of vitamin K may be due to prolonged antibiotic use or broad spectrum antibiotic use, which can suppress the bacteria that synthesizes vitamin K in the intestine. The intestinal flora will be suppressed. That is the reason, because intestinal flora is very important for synthesizing vitamin K. Because of that, you might have a Reduced absorption of this bacteria producing this vitamin K, and that will be absorbed in a very reduced amount. Because of that, you might have a vitamin K deficiency. Because of that, the PT-INR may be elevated. And second is malabsorption syndromes. Typically, what kind of malabsorption will result in vitamin K deficiency? Typically, fat malabsorption. Which malabsorptive diseases will produce fat malabsorption? Pancreatic problems, small bowel disease, and obstructive jaundice. All these three will result in fat malabsorption, which means they will not only result in vitamin K deficiency, they will also result in other fat soluble vitamin deficiencies like A, D, E, and K. Clear? Reduced absorption. Next, you can have liver disease. Liver disease due to reduced stores of vitamin K. Then warfarin, antagonist of vitamin K, it's like vitamin K deficiency only. Then you have something called hemorrhagic disease of newborn. Hemorrhagic disease of newborn. Very important again. Hemorrhagic disease of newborn again typically due to vitamin K deficiency, because the flora of the newborn will be very poorly developed. That is also one reason why we give vitamin K prophylaxis for all the newborns at birth itself. And if they ask when they will bleed, they typically bleed on day 2 to 4. This hemorrhagic disease of the newborn. Again, that's a very important question. These are some of the etiologies of vitamin K deficiency. But how we are going to diagnose? Diagnosis wise, your PT, INR and APTT all will be increased. INR will be increased. This is very important. At the same time, remember APTT also may be increased. Clear? Because it's a problem of a common pathway also. Because APTT also measures the common pathway to an extent. So your APTT may be elevated. So, but the elevation of PT-INR is the most important thing. At the same time, you'll have a normal platelet, normal D-dimer, normal PFA 100, and all these things. So there won't be any problem at all. So this is what you will, this is what makes you suspect a vitamin K deficiency. I have a case report. Let me tell you a case report. 15 days back, this is a real case. 15 days ago, a 45-year-old male admitted with sepsis with a probable septic source from the genital tract, urosepsis, and he went for a DIC. Evidence of DIC was there in the peripheral smear because we saw cystiocytes, and we had elevated D-dimer, and all his coagulation profiles were abnormal. PT, APT, INR, all these things were elevated. So you have seen all these things. And the patient had an end organ dysfunction also. Patient had renal failure as well, typically, and the patient had a lot of thrombocytopenia because of DIC. And we had started on broad spectrum antibiotics, meropenem, because we suspected pyelonephritis. Once we started meropenem, the patient becomes stable, completely recovered, and the vitals are stable, the counts are stable, total count has become normal. The serum procalcitonin, which was initially elevated, it's a marker of sepsis, it was normal, and the creatinine got normal. Everything was normal, and the peripheral smear we repeated, and cystocytes were completely gone. There were no cystocytes anymore, and everything recovered. Patient was ultra stable, but still patient is showing elevated PT-INR. And my intern asked the question, why? So why this is the case? Why PT-INR is elevated? And without my knowledge, they asked a gastro opinion. Okay, fine. That's not bad. They asked a gastro opinion, and they asked them to do an LFT, which was again normal. Liver function test. There was no problem at all. Then that time I was in the class in Delhi, so they called me up. They rang me up. They told the patient had elevated PT-INR. What could be the probable reason? I asked what is the day of meropenem. They told the day of meropenem is day 12. And I told why you are giving for day 12. In a sepsis with pyelonephritis, broad spectrum antibiotics has to be given for 7 to 10 days, and then we can change to oral drugs which are sensitive. The patient is not in sepsis. So my advice was, I told first stop meropenem and give an injection vitamin K of 1 milligram for 2 days, 2 to 3 days daily. This is what I told. They were quite bamboozled, sir. How stopping meropenem will make the liver better, the PT-INR better? I told you it is not due to the liver. It is because this meropenem is causing floral suppression because of that your vitamin K is deficient. That is why you're having elevated PTNR. So correct the vitamin K, because the post-op, this patient is a little bit, they did some procedures also in this patient like URS and stenting and all. So there's high risk of bleeding. So I asked them to give vitamin K to prevent bleeding in case it can happen, and stopping meropenem will make the flora get better and your vitamin K will be back to normal again. So that is what I told. So this is how. So it needs a lot of clinical expertise as well sometimes to predict things. This is a very simple thing. So after 3 days you don't believe, just after 3 days the patient was discharged home with a normal PTNR. Patient didn't have any problem at all. So that's why, like this is all very simple stuff, bread and butter. Okay. So these are the things you have to do for diagnosis. And treatment wise, management wise, what you're going to do. Management, you can do prophylaxis as well as treatment in case if it's a bleeding. Prophylaxis, to prevent bleeding. Prophylaxis is to prevent bleeding. So adults and newborns, there are two people who has to be treated as well as given prophylaxis. Adult, the only indication for prophylaxis in adults is prior to liver biopsy. Prior to liver biopsy, typically we give 5 milligram per day oral dose or a 10 milligram slow IV prior to liver biopsy. So this is the only indication in adults where I give prophylactic vitamin K, otherwise we don't give at all. In newborns, indication is all newborns has to be treated with prophylaxis. Typical dose is 1 milligram IM. Currently, this IM dose of vitamin K has been triggering a lot of controversy in newborns. Even it told like it's increasing a risk of certain cancers and autism. So I don't know how it came up through some studies, but a lot of retrospective studies have proven no, and there are no concrete evidence for this. But still, certain people who are afraid of this might prefer an oral vitamin K. But anyway, it's as safe as IM vitamin K. Anyway, you can give that also. Fine. So now in adults, when you treat, suppose if there is a bleeding, what you will do? Depends on severity of bleeding. It's a minor bleed, you just give 10 milligrams slow IV and you can repeat for 2 days. Repeat the same for 2 days. 10 milligrams slow IV and you can repeat the same for 2 days. Remember, but if it's a severe bleed, life-threatening bleed, severe bleeding, you might be needing to use this 4-factor PCC or even at least a FFP minimum. That's what you have to do, because to replenish the 2, 7, 9, 10 factors. And in newborns, you give 1 milligram IM Q6 hourly, or simply if it's severe bleeding, you can prefer 4-factor prothrombin complex concentrate, like how we did for warfarin. So this is the dose for adults and children, prophylaxis as well as treatment dose. Now final thing what we have to do is the liver disease understanding, liver disease and the coagulopathy. Many people do misinterpret the fact that liver disease causes bleeding only. Actually no, liver disease can cause DIC also. If you take the books carefully and see, liver disease and the hemostatic derangements are extremely complex. You cannot predict what will happen in liver disease, even though bleeding is the most common manifestation, but even they can go for DIC. And the hemostatic derangements that you see in liver disease are extremely complex. That's what you're going to see now. So what are the complex hemostatic mechanisms that are seen in liver disease? Number one, in a primary liver disease, let us see what are going to happen. The hepatocytes are failed, and because of portal hypertension, you will have a splenomegaly also. That is because of this portal hypertension. And the liver cell also has failed dramatically. So because the liver has failed, there is going to be reduced production of, remember, clotting factors as well as anticoagulant factors, which means their levels will be less than 30%. Typically there will be around only 30% of the normal levels will be produced. But the important point to note is the clotting factors as well as anticoagulant factors both are actually reduced. It's not only the clotting factors that are reduced. So you might be thinking that there is a balance between clotting factor and anticoagulant factor, which means there should be no bleeding. Yes, that's a fact. There should be no bleeding, but still there is a bleeding because there is a reduced reserve of coagulation factors, reduced hemostatic reserve, reduced coagulation reserve. They don't have a good coagulation reserve. Both the because when there is a bleeding, this 30% of the factors that are circulating will be consumed very fast, and you don't have the other factor. 70% of the factors, which means the bleeding will be massive, because this will be consumed much faster. That is the reason. So why you don't get this, and why you get sometimes massive bleeding with liver disease as well. So it's the reserve that's the problem, not the actual decrease in the clotting factors that are important, because the anticoagulant factors are also important. By definition, that has to balance, and you should not get a bleeding. Still you get a bleeding because of the reduced overall hemostatic coagulation reserve. That's the reason. But what are the clotting factors that are not affected in liver disease? I told you generally clotting factors, but what clotting factors will not be affected except two clotting factors. One is factor VIII, because factor VIII is not coming from the liver, it's coming from the endothelial cells. Very important. Clear? And typically fibrinogen levels are not affected by liver disease. Most of the time fibrinogen levels may be completely normal. So no need to worry about that. But one problem with fibrinogen mechanism will be there. What is the problem with fibrinogen? Remember, fibrinogen is activated by liver, which means fibrinogen that is produced normally circulating, they carry that sialic acid residue. The sialic acid residue has to be removed. Clear? By the liver. In a liver failure, that fibrinogen sialic acid residues will not be removed by the liver because of hepatocyte failure. So fibrinogen might be dysfunctional and inactive, even though they are circulating in normal amounts. Clear? So dysfunctional fibrinogen. Dysfunctional fibrinogen. So in the sense, because sialic acid residues are not removed, sialic acid not removed from fibrinogen by the damaged liver. But remember, if someone asks you levels of fibrinogen in liver failure, actual levels of fibrinogen are highly variable. To be honest, in the early stages it can be normal, but in the late stages of liver failure it can be normal or even increased fibrinogen you will see. It's a common misnomer that you will think fibrinogen levels are actually decreased. Even though they are synthesized in the liver, fibrinogen levels are not decreased in liver disease. They are normal or even increased in late stages of liver disease. Be clear about that. But even though they are circulating at high levels, they are dysfunctional and they don't contribute in the hemostasis. That's the reason. They result in bleeding. And the third thing, they'll be having elevated circulating TPA, that's tissue plasminogen activator, again due to reduced metabolism. Liver is the one that metabolizes this TPA. So because they have reduced metabolism of TPA and increased levels of tissue plasminogen activator, they'll go for increased thrombolysis, fibrinolysis in the blood, which means they are going to convert more of a plasminogen to plasmin. And this plasmin is going to convert fiber into FDP and D-dimer. So this plasmin also can be increased due to a lot of reasons. This plasmin also can be increased due to a lot of reasons, because there will be reduced production of alpha-2 antiplasmin, reduced production of alpha-2 antiplasmin, and reduced production of TAFI. Both are very powerful inhibitors of plasmin. Both are very powerful inhibitors of plasmin, because liver is the one that synthesizes these two, and because of liver failure both these are reduced, plasmin levels are increased again. At the same time your fibrinolysis will increase and bleeding chance will increase. That's the idea. Clear? Fine. So these are some of the mechanisms. At the same time, liver also produces two other problems. The first problem, maybe we can tell, like the splenomegaly will have low platelets due to sequestration of the platelets in the spleen, which can also be due to hypersplenism, where the platelets are excessively destroyed by the enlarged spleen. At the same time, liver produces reduced thrombopoietin also. Liver produces reduced thrombopoietin, because thrombopoietin is one thing that is going to be synthesized from the liver, and this low thrombopoietin also contributes to low platelets. At the same time, the patient is continuously taking alcohol. Alcohol itself is a bone marrow suppressant. That itself can cause low platelet because alcohol is one of the important causes of liver disease. So all this will contribute to platelet dysfunction and thrombocytopenia, and this also can result in bleeding. Platelet dysfunction, low platelets, thrombocytopenia, and this also can result in bleeding. And that's why I told you, so it's a complex mechanism. So many things are going on, but your exam question will be revolving around your fibrinogen only. I feel so. This fibrinogen, sialic acid residues, what are the levels of fibrinogen? Remember, fibrinogen levels are not gently decreased in liver failure. It's a very common myth and mistake that you see generally. So this is what you do. So this is something important to understand. These are the hemostatic changes that happen in liver disease. Typically in bleeding times, you generally treat with based on the targets. We generally don't treat the bleeding in liver disease with just empirical treatment. Depending on the INR, we give FFP. Depending on fibrinogen levels, we give cryoprecipitate also. It's all depend on quality assessment and the evidence-based treatment. It's not about empirical treatment, the FFP and cryoprecipitate. In all cases of liver disease-induced bleeding, it might be due to DIC also. You never know. If you give fibrinogen cryoprecipitate, and it might worsen the disease also unnecessarily if your fibrinogen levels are normal. So be very careful about that. So let us put a small table and let us see the different coagulation parameters and different acquired disorders. Suppose if you have a PT, APTT, and you have a thrombin time, fibrinogen, D-dimer. Let us put bleeding time. You can equate this to PFA 100. Then platelet count. Let us see some comments if you want. So number one, first disease, we'll put vitamin K deficiency, and with warfarin. Patients on warfarin, what will happen? The main effect will be on very high PTINR. APTT may be high. Thrombin time generally normal because we don't really affect the thrombin time much. And fibrinogen normal, D-dimer normal, bleeding time normal, platelet count normal, and PFA 100 normal. Clear? Usually this vitamin K deficiency and warfarin related elevation of PTINR, usually it normalizes with vitamin K treatment. If you give vitamin K, this will definitely normalize. So that's one point you have to know. Second, aspirin, your PT will be normal, APTT normal, thrombin time normal, fibrinogen normal, D-dimer normal, only bleeding time will be increased, which means PFA 100 alone will be abnormal. Platelet count will be normal. Aspirin is not known to cause thrombocytopenia, only dysfunctional platelets, and it's an irreversible drug, I told you. Then liver failure. It depends on whether you are dealing with a early liver failure or late liver failure. Late liver failure tends to behave like a DIC. Actually, yes, true, DIC is common in liver failure, as contrary to the fact. PT will be seriously elevated, APTT also may be elevated, but in early stage it will be normal. PT will be seriously elevated because 2719 are the first thing to be affected, so PT APTT surely will be affected, PT will be affected. APTT may be elevated in later forms of liver disease, and TT normal, thrombin time normal, and in late disease it might be increased, and fibrinogen levels usually normal in early disease. In late disease it can be normal or even increased. I told you very important point, fibrinogen levels does not drop in liver disease, and D-dimer levels are normal. In later stages it can be normal or increased, very variable, because later stages of liver disease they go for DEC. That's the reason why your D-dimer may be elevated. Bleeding time typically normal, in late stage it will be increased because of platelet dysfunction. PFA 100 may be abnormal, and platelet count may be normal in early but decreased in late stages because of splenic pooling, hypersplenism, splenomegaly, and reduced thrombopoietin levels. All these factors are there. So late stages it's very chaotic. Anything might happen. In patients with uremia, your prothrombin will be normal, thrombin time will be normal, APTT will be normal, fibrinogen levels will be normal, D-dimer will be normal. You will have elevated bleeding time and abnormal PFA 100 like aspirin, and you have a normal platelet levels also. Like aspirin only they are going to behave. And in DIC, again depending on early and late DIC, but classic DIC, PT will be elevated, APTT will be elevated, thrombin time also will be elevated, fibrinogen levels will be dropped because of consumptive coagulopathy, D-dimer levels will be massively elevated, bleeding time also will be elevated typically because of thrombocytopenia you have in DIC, it's a TMA, and platelet counts will be dropped. So the only disorder with everything is abnormal, DIC. isn't it? So then you have a TTP, HUS-TTP complex where everything is normal except for elevated bleeding time, platelet dysfunction and thrombocytopenia. That's it. Heparin. Heparin will cause a little elevation, very mild elevation of prothrombin time, but a massive elevation of APTT and thrombin time, and the fibrinogen levels will be normal. All the other levels also will be normal. So APTT is, we are talking about unfractionated heparin. We are talking about low molecular heparin. Effects are complex with low molecular heparin. So these are the things you are going to see. This might not be that an important table, but this will give you an overall idea about how to go about disorders of coagulation. Clear? So with this we are finishing the disorders of the coagulation. In the next section we will be discussing on the von Willebrand disease, and I think it might need a separate video on von Willebrand disease. Once we finish the von Willebrand disease, we might be moving on to the stem cell transplant and transfusion medicine.